Thanks, Mike. I really appreciate it. Thanks for coming. We really appreciate it. First off, I want to say that you can't do anything without people helping you do things. Once I had the opportunity to meet the president of India. The guy's name is APJ Kalam, and I got a chance to talk to him, and he said, Curtis, it's really easy to have a vision. He said the hard part is getting people to embrace the vision and accept it and help you get it done. And that's really true. Here we've had such a great team to move forward with things, and people that are willing to think outside the box, take risk and do new things. And that's how you change things. You don't do it by thinking the same way and doing the same thing you've always done. So one thing I want to say is I would like to get Adam Rule and the team that put this together. Would y'all please stand up, and so we can recognize you guys, all the people that were involved in getting this off the ground. So we really appreciate it, and so I know it'll be a good learning day. I will tell you that healthcare, you don't have to be a genius to know that healthcare is at a crossroads right now. And in our entire careers, we've always said this, but this time I really mean it, damn it. Really, I do think that things are going to change now, and it's because of money. We're in a crisis with money, and so, money changes most things, if not all things. So that's where we are. So let me pull up the slides. It's on this? Okay, good. Yeah, got it. Okay, so I'm going to talk about the changes facing us and how technology can be used to provide a low-cost, efficient system that will allow us to reduce expenditures and also have better outcomes. I know that seems opposite of one another, but the problem with healthcare today is that we pay people for doing things, not for having great outcomes and being efficient. So as long as you pay people to consume health care, then that's going to be the focus of the way health care is delivered. So and I'll also say that a little bit fee-for-service is the antithesis of fee-for-service. So in other words, fee-for-service gets in the way of changing healthcare using technology, because fee-for-service wants a practitioner to keep that patient, manage that patient, and do things that would make money for that practitioner. And that's just the reality. I mean, I'm a doctor, so I can say that. That's what drives us forward. But when you get out of fee-for-service and then start talking about efficiency and quality management, then it's no longer about you consuming resources with that patient. It's about getting the best practice for that patient delivered, whether it's with you or if it's with somebody else. So that's kind of, and as you do that, then you need a nervous system. You need a network to be able to do that. So that's kind of where we are. So the big thing, I think, in all this stuff is to put the patient first, right? And I'm an obstetrician, and so my patient is the mother and the fetus and then the newborn for just a very short period of time, which I'm kind of glad of, because I don't really like pediatric patients that much anyway, so I get to hold it for a little while and then give it to their doctor. So, but everything we do has to focus on the patient. And if we don't do that, I think a little bit healthcare has lost sight of this statement over the years, and it's been more like a business and not about the patient. So if we keep the patient first in everything we do, then we'll get through this and be in good shape. And if we lose sight of that, we're not. So again, Adam is a very creative guy and done a lot of, this is a great video, and so I'm going to show this video because it explains kind of what we've done here and how it works. So
this is Jennifer's story. Have you ever heard the words telehealth or telemedicine and wondered what they meant? Maybe it's a new kind of medical telephone or some new TV show about a hospital. Instead of trying to define these terms, it's best to describe what they mean with stories about real people. Meet Jennifer. Jennifer is 5 months pregnant and lives in a rural area in the American South. At one of her first doctor's visits, Jennifer was told that her pregnancy could be high risk. She would be monitored more closely than most pregnant women. This means more doctor's visits, more tests, more traveling from her small town, and more time away from work and family. All of this adds up to more money. Now meet Dr. Allen. Dr. Allen works at a regional health clinic 15 minutes away from Jennifer's home. Dr. Allen is a family practice physician and sees all types of patients. Dr. Allen isn't specialized in high-risk pregnancies, but there's a tool at his office that can help Jennifer and her family. The tool is a video conferencing unit. Video conferencing allows two people to communicate in real time over long distances. Sounds like a telephone, huh? Yes, but video adds the face-to-face element that a phone cannot offer. Video conferencing also allows users to send high-resolution medical images back and forth in real time. Okay, back to Jennifer. She has an appointment to see her doctor in the capital city of her state, which is 2.5 hours away. Instead of missing work, finding babysitters, filling the car up with gas, and maybe even staying in a hotel, Jennifer can drive to her regional health clinic and see her doctor in capital city over live video. The doctor can see Jennifer, look at ultrasound images, and direct her care with the help of healthcare workers by Jennifer's side. All this is accomplished by video conferencing equipment and high-speed internet lines. Jennifer doesn't have to take time away from work or time away from her family. Jennifer gets more specialized care, cheaper and faster. That's telemedicine. This video produced by LearnTelehealth.org, a part of the UAMS Center for Distance Health.
So there's no way of saying it more concisely and beautifully than what Adam did in this video. So I have to show it to doctors because it's best to have granimal-like colorful shapes in animals. They can understand that a lot better and follow than if you try to do technology-based stuff. So what's the problem with healthcare? Well, we're the world's leader in the cost of healthcare. Here's USA here, and this is the percent of GDP spent on healthcare and the life expectancy. So while we have a good life expectancy in America, look how much more money we're spending. It's now actually close to 20% of the GDP. So this is an old slide. So we're spending a lot of money on healthcare. And if you look at the average spending on healthcare per capita and and total expenditures on healthcare as a percent of the GDP, you can see that the red line is the U.S. and we're outstripping all the other industrialized nations, well, all nations in the world. And so when you have plenty of money, you can burn it, but when you run out of money, you can't keep burning it. So we're in that phase right now where we can't keep spending money at the rate that we're doing. And this shows how high can it go, and we're now 6.7 trillion in 2010, and that's over 10 times the 256 billion spent in 1980. So that's how much it's increased. And this shows also the distribution of the payment structure, personal, other, private, and Medicare and Medicaid. And so if you look at the Medicare spending per beneficiary in 2006 and the overall quality of health care and the amount per patient spent, you can see this is where Arkansas is, that we're not spending as much money as a lot of these places, but also the level of care we get in Arkansas is way down the chain. And look at Hawaii, which is low cost and low spending. So you want to be in this region over here, low down and high up the chain. So, and you can see distribution like Michigan, Massachusetts has a lot of spending and good care, but they're also spending a lot of money. So. And fortunately, we're not Louisiana, who spends a lot of money and is worse to, Mississippi and Louisiana keep us from being eaten by the tiger, usually, so we're not the worst. And this shows Arkansas's healthcare population and all the problems that we have, and overall, we're 46 in America in terms of overall care. So. And I'm ashamed of that, frankly. I think that's terrible, and we need to do something about it. Now, some of this stuff is related to poverty, and I understand that, but some of it isn't related to poverty. It's to other things that we can do something about, and we need to do something about it. So the Angels mission as we started, and that's Angels is antenatal, neonatal guidelines, education, and learning system. So it's sort of is the philosophy, but the image of it is angels taking care of patients, right? So it says it, and that's sort of the mission. Now, I'll tell you, there's some discussion in marketing about, well, you can't call it angels because of babies dying and little angels, But angels are actually creations of God to do things for God, both good and evil, but they're not dead people, they're creations. So it's okay to call it angels, in my opinion. The first of its kind in 3 state agencies to link, where we had to work when we started this concept, Department of Health, which has been very great partner in all this stuff, and of course Department of Health and Human Services has funded the project since the very beginning, and the University of Arkansas for Medical Sciences that worked together as a team to try to do something about all the problems in the state. And what about buy-in from the medical community? Because in the beginning of this thing, I envisioned that it would be like Frankenstein and the village people. We would be Frankenstein, and the practitioners would be the village people, and they'd want to come and kill Frankenstein. And so you have to be very careful that we weren't Frankenstein. So we went out of our way to talk to the medical society, hospital associations, and tell them that we're not trying to take patients away, and we've been very cognizant of not having people fear us by taking patients away. So we really want to move patients around in a very proactive fashion, and then move them back to the community. So move them out quick, treat them, and move them back where possible. And that's the idea. In the obstetrical program, we've left the patients in their home and treated them there the majority of the time, and haven't really brought them to the university unless they need special services, or unless they're going to deliver at the school for some reason, like newborn surgery for congenital anomalies. And so medical served areas are all over the state of Arkansas. 73 out of 75 counties are designated as medically underserved. Healthcare access is the most overwhelming reason for Arkansas's poor. I'm going to tell you that if you think you're going to be able to put doctors in all these counties, you're crazy. It's not going to happen. I mean, it's just not going to happen. You can put a few doctors in some of these places, but we're not going to solve the healthcare problem in America with MDs. It is not going to be possible. So we have to look to other alternatives to providing health care besides the traditional model of everybody has to see an MD at every visit, because that's not going to happen. Last night we're talking to Dr. Schaefer, and he was in Nebraska, and Nebraska has apparently 1 million people per the state of Nebraska. And I thought we were sparsely populated. We have 2.5 million in the state of Arkansas. And there are other states around the nation with even less, Alaska, Wyoming. And so it's just not possible. But you can use, sort of other kinds of personnel to help you deliver care, which I'll talk about a little bit in a little while. Healthcare disparity in Arkansas, we're pretty good in the urban areas. I mean, we're equivalent to any place else in the nation, but you move 30 miles out of the urban centers and the health care drops way off. The access, the procedures, and often patients have a hard time, moving to the large cities. Arkansas is not a big city, but there are patients in southeast Arkansas who are afraid of coming to Little Rock because they're afraid they're going to get lost and it's too big and they don't have transportation. So where you live should not determine whether you live or die. And I think using technology can reduce a lot of these issues. Of course, trauma and things like that, acute things, we can't do as much about, but there are a lot of things we can. So Albert Einstein said, insanity is doing the same thing over and over again, expecting different results. And so if we continue to say we're going to solve the shortage by just putting doctors all over the place, it's not going to work. So we have to come up with new ways of delivering care. So this is a single neuron. And so you can take it in the lab and study it. It can't do much. It's one single cell. But through its connections, it begins to take on a new light, so it can connect to other cells. And these cells, these connections to other parts, and then you have a brain. And so I like to think the tertiary care centers are the brains of healthcare, the big centers, metropolitan areas where you have all the specialists and all the procedures. But in the past, we've been isolated, mainly in urban areas. So what we need is a nervous system. And as we begin to develop a nervous system, technology allows us to do things across great distances that we can't do in a traditional healthcare system. Now, when you say nervous system, we talk a lot about telemedicine, and that's sort of streaming video. But what I'm talking about here is not just that, and that's a part of it. But it's not even maybe even the biggest part of it. From the point of view, I mean things like guidelines and protocols that everybody would use. I mean mHealth, where we have sensors that the patients are wearing, and it's collecting information, and we're doing things that based on the sensor input on unstable patients. So we need to be matching the level of service and sensing and intervention based on the instability of the patient. And the traditional kind of idea that we'll just put all these people in the hospital is wrong, because we can't afford to do that, and it's not even in the patient's best interest. People with congestive heart failure are going to always have congestive heart failure. They're not going to get well. Their hearts are bad. So if you think you're going to put them in the hospital and manage them the rest of their life, you're crazy. We have to be able to take these people and monitor them in their home environment, and then be able to stabilize them when they become unstable. And the only way of doing that is approaching it with how can we deploy sensors on these patients, how we collect information in a new way. And sometimes it's as simple as just weighing them daily and getting their weights and having that come into a central place. But other times it can be actually monitoring their EKG signals, and soon we'll have biomedical chips that can assess electrolytes and things like that. So that's going to be coming in the not too distant future. And the other thing is kind of managing them as a system and not having it as an individual cell. What I mean by that is that systems approaches to this kind of patient can really do a lot to keep them out of the hospital. We're going to be expected to keep them out of the hospital. We're going to be paid for keeping them out of the hospital. We're going to be paid to keep them healthy a greater period of time and not treat them when they get sick. So the concept that we're operating on right now of treating disease is close to being over, and when we focus now on how do we keep them out of the hospital, then I think that's when we're going to see dramatic change. So this is how nature works. Nature is a branching tree-like structure. This is your lungs. This is the placenta villi and the placenta cotyledons. It's a branching tree-like pattern. And it does that because it's efficient. This is one of the most efficient shapes in biology. And so it also resembles perhaps a computer network, right? So, I would tell you that I don't think that we think of new things that much in nature. These shapes and things are copied over and over again. So imagine now that this, instead of being a tree, is an obstetrical management system where the maternal fetal medicines are the trunk of the tree. And because I'm very proud, I'm a maternal fetal medicine specialist. That's my specialty. I spent my entire career learning about pregnancy and the fetus. And there are a bunch of other people at the school that do this. And then we have a few people around the state that are maternal fetal medicine experts as well. But we should be helping the system be as efficient as possible. And we can do that with technology. We couldn't do this before technology. So if a patient somewhere in the leaf here of this tree, that would be maybe a patient has a problem, we can identify it and move it up, treat it, and then move it back down to the periphery where it should reside the majority of the time. But we need to be able to sense, we need to know this is going on, sense it, and then have a plan to intervene, which we're developing now as we move forward. And so the Affordable Health Care Act brings more covered lives in the healthcare system, but it's going to be necessary to develop a multidisciplinary care network to respond to this massive infusion of new patients. And also, another secret is that we're going to have a lot more patients, but we're going to get paid less for taking care of these patients. Not more, but less. So ultimately, any way you pay it, we're going to have to do more with less. The traditional model of physician-patient interaction is not going to be able to be sustained long-term because doctors can't see many more patients per time slot. But by using their expertise and working with other healthcare providers, we can expand our capacity, and that's what we're going to have to do. And so if we're going to get paid less money and have to see more patients, then what we're going to have to do is reduce our production costs, right? That's the only way otherwise we go out of business. If you're going to have to get paid less money, see more people, and you can't reduce your production costs and increase your production, you're going to go out of business. So what we're going to have to do is look to other kind of providers that cost less money than physicians, but work in teams and so that every practitioner practices at the upper level of their license. And what I mean that is that APNs have to be practicing at a very high level, but supported by the expert that helps them with guidelines and protocols and rapid input to care management. And that's the only logical solution. So the other thing that we have to do is we have to look at our practices, how we're doing things, because if we're being wasteful with healthcare delivery, then we're going to go out of if we continue to waste money like we're doing it at present, we're going to go out of business. And we are going to have to work with hospitals and within our own clinics to look at it and say, what are we doing that's inefficient? We may have to look at the way we see patients in a different way. We had a discussion this morning at breakfast about using group counseling of patients. There's a thing called Strong Start in pregnancy, in which you have pregnant women that come in together in a room and they establish a peer relationship, and we educate them as a result of this group relationship. And that can be done by a non-physician person, and a lot of what we need to do in pregnancy is educating. Pregnancy is not a disease, contrary to popular belief. It isn't. It's a normal physiological process. If it was a disease, I doubt many of us would be here today. So it is a normal physiological. But in the healthcare model, it's been sort of a diseaseified, if you will, so that it's treated and managed as though it was a disease, and really it isn't. It's a normal physiological process, and we need to kind of begin to think of how can we treat it like a normal physiological process, and how can we educate young women and identify existing problems like, for instance, preeclampsia or diabetes, those sort of things, and then treat those patients in a more specialized way so that they do require a lot more work. And my specialty exists because of this, in fact. But routine patients don't really need to see me or even an OBGYN. I know that's heresy, but even necessarily an OBGYN. So that's the way we're going to have to work down the road. And these systems engineers allow us to look at what's going on and apply an interdisciplinary approach and means to enable the realization of successful systems. It focuses on defining customer needs and required functionality early in the development cycle, producing requirements, then proceeding with design systems and systems validation while considering the complete problem. So it looks at the complete problem of care delivery and figures out where the bottlenecks are and plans interventions to fix the bottlenecks. But it requires somebody to come in and look at the entire process. We've tried to improve C-sections, elective C-sections on labor and delivery, and I can tell you, no one understands how patients get admitted to labor and delivery and then get an elective C-section and get to the postpartum. No one person really understood that. So we looked at it, though, as a system from the very beginning and collected information and said, what happens point 1, point 2, point 3? They get admitted, they go get pre-op, they go to the operating room gets cleaned up, they go to postpartum, and so, it's a system, but we never looked at it as such. Everybody had their part, but no one looked at it. So it has to be a team effort to forming a structured development process that proceeds from conception to production to operation. Systems engineering considers both the business and the technical needs of all customers with the goal of providing a quality product that meets the user needs. So we have to think like this. And the role of the individual physician has been an individual siloed mentality, not connected. Now what we have to do is we have to look at it as a team approach with the teams being connected in groups, so the physicians, assistants, pharmacists, APNs, nurses, paramedics, and lay healthcare workers should be incorporated in the delivery of healthcare to the extent possible. And they all need to get together and talk about what they're doing to deliver care. I mean, we can't run it as though, the doctors were the boss of everything. We got to work as a team, and we got to say, well, what do we got to do to make this happen? And that requires us changing. Now, I do think the experts need to have input in the whole process. And so whether that's an MFM at the university or a family practitioner in Mena, Arkansas, they need to have input in the whole process, but they need to work with the team in order to make things happen. And the hospital beds are a loss. So we need to be thinking in the future about how not to have people in the hospital bed, but have the patient managed at home. Less visits, and ultimately the ultimate primary care provider is the patient. And that's the truth. So they're the ultimate. And as we move closer and closer to that patient in terms of our management structure, we now, you have to schedule a visit. You're having a problem, you have to schedule a visit with your doctor, maybe see him for 2 to 4 weeks. In the meantime, your condition could have deteriorated and you could have been admitted to the hospital for congestive heart failure. The best example of this is asthma, right? Asthma is a condition, particularly in kids, that they can have flare-ups, and often they end up getting admitted to the hospital, whereas if you had a nurse they could call in the middle of the nighttime, for instance at 3 a.m., that nurse could run a protocol, increase their albuterol dose, maybe start corticosteroids if they're not on it, and then they could avoid the hospital admission. That saves millions of dollars, not to mention it's better for the patient ultimately. But that's a systems approach. And if you get paid for having people in the hospital and get paid more money for having a person in the hospital, and you have to get it at 3 a.m. and it doesn't make any money for you, it doesn't take a genius to figure out that would be not the best idea in the world. And that's what in fact happens in healthcare today, is often asthma patients are admitted unnecessarily, both adults and children, more commonly in children. And so we got to look at other resources like cell phones, and the concept should do to do the cheapest, most effective means of delivering care. And the good thing about cell phones is everybody has one. In third world countries, they skipped wired lines and they went right to cell phones. So you can, in Nepal, you can get a cell phone, and you could never get a telephone line. So the opportunity of using these low-cost devices is quite amazing. And so in a connected healthcare world, there'll be traditional telehealth consults. There'll be remote care, remote monitoring, and remote care delivery. Absent cell phones, individual and population-based care management is the way we'll be doing things. And so the goal should be continuous process improvement. If you look at this curve, the standard curve, you look at how it needs to be moved. And what we really want to do is continuously look at new innovations and move the curve forward so that there's best performance of the system. And I will tell you that I don't think there's ever a system that can't be further optimized, because there's new breakthroughs and new things happening. But we need to be building continuous monitoring systems that allow us to, like a factory, exactly like a factory, where we're monitoring production. And the goal should be to make quality, efficient health. That's our goal. That's our product, is good outcomes. Not volume, but good outcomes. And so you look at this process improvement of where you do plan, do, check, act, and that's really kind of the way you look at these systems. When you've mapped out a flow pattern, you find a failure point, and then you get groups together and they plan what the improvement would be. And this involves like nurses, doctors, cleaning people, everybody, if there's a failure point. And you talk about what you're going to do. And if there's somebody that's already done it, then you obviously would use that. And that's going to be beneficial to us as people do these things. They'll discover like something that comes out of improving C-section or labor and delivery could be used across the healthcare network as we do it. But then if you don't know, then you plan an intervention, and then you do, and you check, and then you act to hold the gain. So often this requires us to have sensors or ways of monitoring the process continuously to look for deviations. Often systems want to go back to where they were. In my career, I've done things that were great improvements, and I look back 6 months later and it's functioning just the way it was before because we didn't continue to monitor it and hold the state. So it's very important to kind of build in these a systems approach where we're not only fixing things, but we're monitoring to make sure they're not going back to steady state. And so, like I said, technology is our nervous system, and in this program we've built a T1-based system all over the state, and this is a very robust, high-quality, reliable system where we have the units that we deploy around the state, and we've been able to come up with funding to give these units to members or to systems around the state. And right now we're paying for the T1 lines. I've never seen ever a system in the world that said, we don't need this much bandwidth, let's go back to a lower level of bandwidth. All systems in the world continue to want more bandwidth, and that's a true statement. You can't find an example of where that's not true, because as people get connected, they just think, well, what if I could do this then? So look at the internet. And so these are the equipment that we give to people around the state. And then, at times, and education is a form of healthcare delivery. It's not separate, it's part of it. Because if we're going to become more efficient, then we need to improve healthcare, and I don't know of a way of doing it except by education and sharing stuff with people. And so archive, live stream, interactive are ways that we've done this around the state and the way other people have done it as well. And so telemedicine can be delivered by teleeducation, teleconsultation, telepractice, so you're actually practicing telemedicine. And in this case, you might not have a local practitioner working with you. Teleresearch. And so I'm going to show a video of how we've done obstetrics in the state of Arkansas. And we started with obstetrics as appropriate in healthcare since that's the beginning of life.
See the heart beating there on the screen? Angels is really a new concept in healthcare delivery. The concept is that you don't have to be face-to-face with the patient to deliver the health care.
Why were you sent here to see us?
My doctor in my previous ultrasound found some cysts on the brain of the baby.
Arkansas is a very rural state with a few large cities, and the health care is dramatically different from urban versus rural areas.
You can see the baby's face, the heart beating.
Many of the people, they're poor and they don't have good transportation, so it's impossible for them to travel these long distances. Yeah, it looks fine. The baby's heart rate's a normal rate, and we can see the 4 chambers of the heart even now.
With this technology, we can virtually go visit these patients where they live and provide the care that they need. We are establishing virtual patient visits using this system. We're doing virtual consults around the state, and we're doing virtual education to all points of Arkansas. Shannon Behringer, genetic counselor, is here, and she's going to talk to you about that, what that means.
The thing that you're at increased risk for, however, just because they saw those cysts, is the risk for the trisomies. And the MDS-MTCs can rule those out. I've looked at your...
Without this technology, I don't know how I would have made it to Little Rock to see Dr. Lowery. There's no way I could afford to take a day off to drive the 3 to 4 hours it would have taken.
You always look for other markers of Down syndrome too. So.
My baby needs this for her health. I need this to ease my stress level.
This technology allows us to be virtually anywhere. The neonatologists here at EAMS can be virtually present in the hospital prior to the transport of the sick newborn infant.
First thing it does, it helps us to get an overall assessment of how the baby's doing. We can get a lot of visual clues from what the referring physician is thinking. How's your baby doing? Well, that's good. So being able to do that is going to be a tremendous help.
You're kind of following up now that I'm back home so far away from the hospital, but the baby.
It allows us to make critical and time-sensitive decisions about patients from outlying hospitals.
I appreciate you talking with me. It saved me a big trip.
You might think of this as the nervous system that allows us to make the connections. Through this technology, we can be virtually anywhere, anytime. You know, it's very gratifying to be a part of something like that.
Okay, so we've been doing this for more than seven years, so it's not like, and we do as many consults over interactive video as we do with patients live in our prenatal diagnosis center. So it's an example of an effective delivery. And so with the telemedicine deployment and the way we do things, we've developed a plug-and-play mentality. So this started out with OB, but now we're plugging stroke, the stroke center in, and we're plugging other kinds of healthcare. We've plugged colposcopy in the system. So we do gynecological colposcopic exams around the state using it. So, and as the payment structure changes, then the superhighway will be used for a lot more consultations and care delivery because it ends up being much more efficient. I had a discussion yesterday with one of my faculty, and my faculty needs a PhD to support something in her practice. And so we don't have such a person really here at UAMS or anywhere in the state. And so we thought about the idea of using a faculty member from somewhere else to support her practice virtually, because it's all intellectual. Most of it's intellectual. But I have to have somebody overseeing this lab. I can't deliver it locally. My alternatives are buy one, which would be very expensive, or use part of one from somewhere else. So that's kind of the way you got to think. That genetic counselor, Shannon Behringer, is here in Little Rock, but there's another genetic counselor that we use that lives in Fayetteville and has lived in Fayetteville since the beginning of the problem. So that person didn't want to move back to Little Rock, so we said, well, hell, let her stay there. What difference does it make if she's doing interactive video? And so that was really kind of a break for us to say, well, what difference does it really make? If it's all interactive, it It doesn't matter if she's in Little Rock or in another state, theoretically, she can do her service over the system. And it's worked very well. We haven't had any trouble. In fact, we've used that person in Fayetteville to do consults in our prenatal clinic here in Little Rock. Even though this is a live clinic here, if one of the genetic counselors were out, we used her to counsel the patient even though she was in Fayetteville. It's kind of interesting. As you begin to think about it, you can just sort of use it as a tool more. And then education and training providers, centralized tech support and scheduling, telemedicine network and infrastructure, and evaluation and research, and case coordination and evidence-based guideline protocols. This just shows the timeline, the beginning of this program, but even before this, 10 years before this, we were doing high-risk OB conferences on Thursday morning, and I guess you might consider that the beginning of the whole idea, but really the thing that we sort of developed was care delivery over the system and how to use this as a part of traditional healthcare care delivery. And you can see the timeline, and then we were, by the work we'd done, we were able to apply for this broadband technology opportunity grant and get money, $102 million to build the Arkansas E-Link. But without all this work going on prior to this, there would have been no chance of getting this funding. We were the only healthcare network, traditional healthcare network that received the funding directly. And we were the second largest award of any of the programs. And so the idea is using UMS and other medical centers. Baptist uses the program as well as some of the other units around. Some of the other smaller hospitals even communicate in a more local level using the system. So it's a public system. It's not just a UMS system. So other programs can use it. We built that from the very beginning. And we started at the very beginning with a contract with Medicaid. And the initial contract, I'll tell you, that is $11 million. And it's more than that now. But we had started out with, $500,000 with the idea, and then it grew to $1 million, then eventually got to $11 million. And I had to go before the state legislative committee and present this, and there was a lady ahead of me that was asking for $2,000. They spent like 45 minutes beating this lady up over $2,000, and I said, oh my God, I'm going to be here for like 2 weeks answering questions. And our legislative group had prepared everything and talked to people, and they went, Angels program, $11 million, anybody have any questions? And I had on my white coat, I was all prepared to answer questions, and then, although somewhat fearful. And they said, anybody any questions? And no one said a word, and it went through. So it was like $11 million, like that. It's just quite remarkable. And since then, we've had not very much trouble with the budget. But the idea is decrease healthcare disparities, save the state money, and increase the quality of care. And so we started with level 1, the Angels concept, and then we developed internal government relations and Medicaid. So we worked with Medicaid, and then the legislative branch, the lobbyists worked with the government to move forward with it, and then hospital administration, the governor, public health, welfare, state legislative committees. And then, like I said, we had to work with the medical society and the state health department to engage prior. So there's a lot of, when you build the highway, a lot of the work goes before you put the asphalt down, right? You prepare the road bed, and that takes the majority of the work. So that's kind of the way this was as well. And so the Center for Distance Health, obviously, when we started this stuff, in the very beginning, I knew it wasn't just an OB program, because why would you build this expensive infrastructure and just have OB run over it? So we built it with the idea that it was going to be plug and play for other systems from the very beginning. And so the next one was Arkansas Saves, which was a stroke program, which really needed to be done because we're the worst state in America for stroke. We were actually 52nd, and I said, how the hell could we possibly be 52nd? Did we get like, F minus or something? And they said, well, no, the territories count. And so they're the 2 territories. So we were below the territories. And then now we're multidisciplinary. And then we've had really incredible support from the congressional delegation and lobbyists and the now extinct Blue Dog Democrats, I guess. Really, they're sort of not totally extinct, but they're endangered species. They're now Blue Dog Republicans. So Delta Regional Authority, and then the state, the Orion, which is a fiber optic network across the state. We took advantage of the existing structure that And I actually had to go before the governor and talk to the governor, and he said, are you going to use that Arion network that we built that cost so much money? I said, yes, sir, we're going to use it. We're not building another fiber optic network. We're going to use the one that you built, sir. And so he said, okay, well, good. And we did use it. So, and then the ATOM board we formed, which is an oversight board to help with the planning the program. And then Arkansas has a broadband council that tries to deploy broadband around the state. And then there's other advanced communication, IT, and legislative committee that we work with. So we're very engaged. And so you've got to sort of begin to illustrate cost effectiveness in the program. And, you know, we have to look at this like it's a factory, right? I mean, that's the way we need to look at healthcare. And while that seems boring, it really does allow us to get orditudes of magnitude of efficiency. And so we got to think about it as what is the right thing for each person in the production to do. And if somebody can do things better and more efficiently than you can at a lower cost, then they need to be part of our production. And so that's really kind of the way we got to go. And so when you look at this, Aristotle said the whole is more than the sum of the parts, which is absolutely true. So you put it together, and it does become sort of a more efficient system rather than just each individual practitioner's working. It's very complicated. There are 815,000 doctors, 3,000 hospitals, 72 million admissions, 3.8 billion prescriptions, and 208. In 2008, there's 2.4. Now I told you we're up to like 2.6 trillion and 20% of the GDP. So healthcare is like a big elephant. And this is the old story of the blind man and the elephant, of which the blind men each felt a part of the elephant. And one said, it must be a tree because it's a big round thing. And the other one said, no, it's a snake because I can feel it. And so, and each one had a part of the whole problem, but never understood the big problem. And so we've got to begin to understand it. You know, it's what drives the spending? Well, patients are part of the problem too, because patients often have limited or no co-pays, and so they want to just get stuff done. And sometimes it's not in their best interest to get stuff done, I'll tell you. The hospital wants to have people in the hospital and seen efficiently and then discharged in the appropriate amount of time because they're DRGs, and the healthcare provider wants to take care of the patient and deliver quality care, and they get paid for doing things. So, you know, they want to do things, and the insurance provider doesn't want any of this stuff to happen. They want to shut it all down and have not to work. You know, in the past they could just pass it on to the companies and to the government, but they can't do that anymore. So they're being squeezed out of business. So, you know, what they're doing now is they're saying, you know what? It's not our problem. It's all you guys' problem. So you figure it out. So that's where we are right now. So we better begin to figure it out. So you don't always get what you pay for, but expect to get what you pay for. So if you pay for doing x-rays, and the more x-rays you get, the more money you get, expect people to do x-rays. In systems for which they cut the funding to the doctor for each x-ray, they often see in these systems a doubling of the number of x-rays that have occurred. So the physicians were able to maintain their cash flow by just doing more x-rays. And so you have to be careful in the way you try to incentivize these things. We get paid in a parallel system. The healthcare provider gets paid, it's procedure-driven, silo-producing, and anti-network. The hospital needs admissions, they need short length of stay, and they're dependent on the physician. And they get paid on daily rates. So in obstetrics, there's a daily rate they get paid for obstetrical patients, and the patient stays for extra days and it's not justifiable, then they don't get paid. And so the hospital is very, very kind of controlled by the healthcare providers. You know, they have little control over tests that we order or the number of days we have patients in the hospital. So they want us to sort of respond and drive things down if we can. And so as we begin to build these networks around the state, the subspecialty healthcare access allows some patients to remain in their community, which is beneficial to the local hospital. Community receives the market share of the deployment of these systems. And so it meets the psychosocial needs of the patient to be near home and allows providers access to current best practices. So it's, in a way, it's an on-the-job kind of education for the local providers. And it does enhance rural economic development because you have quality health care in an area for which there's low-cost workers, then you can recruit factories in. So, but without health care, often it's difficult to get a company to put a factory there because the management people don't want to live in a place where they got bad health care. So healthcare is very important to economic development, much more than people realize. Not to mention the fact that in America, the #1 economic engine is healthcare, more than anything else. More money spent in healthcare, and it drives the economy more than any other system. So if you collapse the healthcare system, you can have a pretty dramatic impact on the quality of the system. So how do you start? I mean, I've said a lot. How do you begin? Well, you don't begin at the top. You begin at the bottom, and you have to figure out how to climb from the bottom up. And that's the way we did, and that's the way we'll have to continue with this stuff as we begin to modify care delivery and use systems engineering. So the first thing is try to seek pilot funding in some way, whether through the hospital or through the Medicaid or through federal funding that gives you some money to start your idea. So if you want to follow what happened here in Arkansas, the state and federal levels, we got money, and then the federal appropriations, we would have senators that would have earmarks that they could send to Arkansas, and some of these earmarks would go to UAMS into telehealth. And then we got FCC pilot money to fund it. And the governor's office, when we got the FCC money, the governor said, we'll give you the match for this money. And so that was really good. Again, the governor knowing about telemedicine and supportive of the project allowed us to get funding for that. And then Medicaid contracts. And then we got other grants like SAVES and Touch because, again, we're building on the foundation that we built years before. And then we've gotten grants, stimulus and seed money. And we led to the BTOP money, and then now we're in this summer we'll begin the sustainability part of the program. And frankly, if people don't want the system and it's not useful, then I don't think it should be sustained. Now, I don't think that's going to be the issue, but I mean, building a big program that fails is not what I'm interested in. We've constructed a system now that's ideal for support of healthcare reform. As we get in healthcare reform, I believe that the system will begin to take this and use it, and it will bloom like desert flowers, because I think it's logical and it's set up. So the advantage that we have is we have a super highway for commerce to drive on. And the commerce is going to be sort of healthcare reform. How do we do things better, cheaper, faster? And I think that's what we're going to have to do, and I'm confident that the system will begin to look for this network to help in a big way. So the Centers for Medicare and Medicaid Services has been very beneficial in helping us. We've got to work with reimbursements and policy involvement to change the way they pay in order to pay for telemedicine and pay for some of the things that we're currently doing. Working across state boundaries, that's a problem because we just got through getting licensed in Oklahoma, and it took for damn ever, and it was hard, and they do background check. You better not have stolen somebody's lollipop when you're young because they'll find it and give you a hard time. So these medical boards are cumbersome and ridiculous, and we need to come up with some kind of national way of doing this. And some of this is competition. They want to keep you from competing for services, but the truth of the matter is in the new healthcare world, you need to be able to compete effectively. So if you can't compete effectively, then you may not make it through the post-apocalyptic world that we're facing in the next few years. So the idea is figure out how you can do things better, faster, cheaper, and then you can actually become the new growth after we change. So the BTOP money is been deployed. This is how we spent it: $28 million to construct fiber, $22 million for telemedicine equipment for hospitals, $5 million for network equipment for community, $24 million for connectivity lease line charges, and $23 million for network infrastructure. And so this is the timeline. It'll soon be over with. This summer we will have completed ahead of schedule. We're the poster child of BTOP money spending around the nation. Recently we got the opportunity to present it at Brookings Institute because of the excellent job that Deborah Green and the group that deployed the BTOP money did. It was just excellent work. I mean, very classy, well done, and Ariane people helped us around the state, so they're part of this in the two-year schools as well. And so the BTOP will benefit the healthcare, but also higher education and libraries, public safety, and research and clinical trials as a result of deploying this. And the E-Link benefits rural physicians and other healthcare providers will collaborate to offer new services to their patients by conducting clinical consultations through the interactive video, leveraging the expertise of specialists. And so these are some of the services that we're currently delivering at UMS through the system, and it'll continue to expand. Arkansas Saves, Human Development Center, cardiology, and we're working actively with the prison system now to almost, I think, eventually maybe become like an ACO organization for the prisons down the road. And this shows the deployment. I apologize for just being slow, but it's kind of an interesting slide that shows the deployment of the system around the state. And so it's across the healthcare spectrum. You know, it's not just about the fetus and pregnancy, it's all the way through life. That's the way this virtual healthcare stuff will go. And the Center for Distance Health, we called it distance health, not disease, right? Because the idea would be to keep people healthy, not treat them when they have disease. That's the idea. And so we do visits with distant providers, doctors and specialists for consultations, x-rays, CTs, other medical imaging, medical histories lab, and some of the statewide electronic record stuff will probably use the network to send stuff. And it allows the growth of healthcare professionals. Healthcare entities can offer new medical education opportunities and coursework and interactive video and online courses to students around the state, and nursing students and other places in the two-year schools are using it to help train their nurses. And so you can get a lot of your work and not leave your home, so you don't have to move to Little Rock to go to nursing school or go to some other kind of school. Public safety can support higher education institutions by offering distance education, CPR, emergency response, campus, and other kinds of things. So change is hard. The imminent need for change, there's no escape the realities of healthcare. We're on the brink, and this time I mean it, damn it. So we're going over the edge. So the question is, how can you control the healthcare bull? It's big, cumbersome, and out of control, and people have tried. You know, administrators have tried, government has tried, and no one can do it over time. It's all have failed. But there's a ring in many of these bulls, and every bull has a ring, in fact, and that's us. We're the providers. We're the ring. So you don't have to control the bull. You just have to control the ring, and that's the approach of healthcare reform today: is controlling the ring. And we're the one ring that binds them all. That's us. And I have a doctor there. I know that's sort of biased, but I'm a doctor, so you know it's okay to be biased. And we're the biggest knuckleheads of all, so it's okay to do that. So you control the healthcare providers, and that's the way you control the system. So, and that's what we're going to be doing. I mean, all of this reform in Arkansas is largely aimed at the providers more than anything else, to control us, to get us to not order tests and not do unnecessary admissions. And so it'll probably work, you know, because if you don't do it, they'll find your bones in the desert, you know, as a dinosaur that died off. So that's the truth.